So I'd like to give the experience from Zambia in terms of the viral load scale-up. We have close to 1.2 million people, or just slightly over, estimated living with HIV, and close to 1 million people are on ART. We have looked at 4 key factors for us to scale up the services, which are high-impact practices: case finding, linkage, retention, and viral load coverage as well. And with viral load coverage, of course, there are different aspects that we have engaged on, not just the coverage, but also how are you utilizing the viral load results. In 2017, our coverage for viral load was 19%, and we saw this as a challenge. Our algorithm then, we had changed it to having a routine viral load done at 6 months after initiation, then thereafter every 12 months. And those that were not suppressed, they had to undergo enhanced adherence counseling. We came up with an implementation plan for 2016 to 2020. And despite coming up with this, we realized that there was inadequate capacity for us to meet the demand. We had, the equipment that we had was, of course, not adequate. Then there was also no well-coordinated mechanism for sample referral. And we also lacked monitoring of those that were, to monitor the suppression levels. And also as a challenge, which we had, is even we had viral loads in certain facilities available as results, the action on those viral loads was also lacking. So these were the challenges that we had. Then in 2017, we had 16 equipment placed around the country. And these were largely from, in fact, all of them were from one vendor. And we decided to come up with a viral load task force team as part of the technical working group. And this task force team meets monthly, looking at various factors, and it's chaired by the lab and also the clinical coordinators of HIV services. And there's representation from the implementing partners and also from other stakeholders, the Global Fund, and also PEPFAR through the 2 agencies which are supporting the program. We came up with a projection of the saturation for viral loads. We had to estimate how many viral loads we needed for us to reach certain targets. Our target for 2020 was 80% coverage. Then also, we had to review the procurement and supply chain so that we'll be able to have adequate stocks available for viral loads. Another area that we had to review was the mapping of the data systems as well, the DHIS and also the DATIM. The DATIM largely for the PEPFAR supported projects, but the DHIS incorporating both the PEPFAR support and also the government or non-PEPFAR supported programs. And in that, we had to link it to the electronic health records for mapping of the data systems. Then another thing that we did was to fast-track the validation of the new technologies. Our platforms, when they come in country, before what used to happen was that they would undergo extensive evaluation. So we moved this to just having these being able to be just validated. Then also we had expedited review of certain technologies that had been used in the region. Another thing that we introduced on the new technologies is also to have the platforms be on rentals as opposed to outright purchase, so that the maintenance of these technologies or the platforms would be by the vendors. And we came up with an algorithm or a cascade of monitoring those that are on treatment. If they are eligible for viral load, each facility would report monthly, and also to monitor how many viral loads are done at each facilities, then also the suppression rates. Important also was the return of results as well. Despite this, we realized that because we have different facilities across the country and we only had then 16 platforms in the country, we had to do the mapping on facilities which are providing ART. We looked at the routes and which one was the best model for them to transport the specimens to. So using the GIS mapping, we came up with the location of the facilities and also linked them to the hubs which were the primary testing facilities. Then also we looked at the capacity of each of those testing labs. We looked at the equipment which was available and also the deficit at each of those facilities, bearing in mind that they were covering a number of facilities outside even their catchment. We had, these are the equipment which we have right now. Then we only had the equipment for 1 and 2. And if you look at the throughput as well, it was very low. So we had to think of bringing the high throughput equipment, which can do above 300 tests every 8 hours. Then also we had to look at having shifts done to maintain the production or the processing of the viral load tests throughout the day. So we had 24-hour shifts as well introduced. Then for certain facilities, we had to introduce the near point of care. Mostly this was the gene expert and also the layer Q that we had to introduce, and had to use the gene expert also for EID, viral load, and of course, currently we're also thinking of HPV DNA for cervical cancer using the same besides the TB. So we had to leverage on the existing near point of care platforms which we had. So for each of these platforms, we had to look at the pro and cons, the use, the throughput, then also the human resource needed to operate that equipment, and the space or infrastructure which we had available for us to determine which one was the best equipment to place in each of those testing facilities. Then also we looked at the ease of the training. How easy was it to train the staff to operate these high throughput equipment? And also we had to look at the storage as well. There are some which needed the -20-degree storage of the samples. And we came up with a recommendation of the placement by the different labs which were available. And from that, we're able to note that with the equipment, if we brought in the equipment, which we now have about 35, then we'd be able to saturate in terms of coverage the whole country. The recommendation, of course, in terms of the placement by site was the infrastructure, the transport systems, and also the human resource as well. What has happened over time since 2017 is that in terms of the viral load coverage, we are now at 58%. This was as of February this year, from 19% just under 2 years. And also in terms of are we on path to reach the 80% coverage? We think we are on the path to have the 80% coverage with an estimated 1.1 million tests to be done this year and also 1.4 million to be done next year. And this is based on the treatment current for the number of patients that we have who are on ART. Then we also implemented the MMed tools as well. So from the central labs, which are the testing facilities, and also from the hubs, which we are receiving the samples and the facilities, we had to implement the MMed to make sure that we had the lab requisition forms available, the referral systems was working, and also the electronic health records and the lab sample tracking tools as well available. It was interesting hearing of the U=U campaign. We started it in Zambia. It was launched by the president 2 weeks ago. So Francois, I'm sure if you should be glad that you won that debate from what I heard, but countries are moving on with the U=U campaign. We think it's important for us to link this to the viral loads so that patients themselves can know that they have an ability even to control the HIV spread as well. We also emphasizing on this the benefit of antiretroviral therapy. But starting with that is the use of the knowing the status, so the HIV testing linked to the U equals U campaign. What are the challenges that we have seen? The viral load suppression in the pregnant women is lower than the national average, and also in the pediatric population as well. And also the action on unsuppressed viral loads, like this is an example of when you look at that cascade, not all facilities are able to act on all viral loads, especially those that are not suppressed. So not all are able to be changed to second line, then even those that need third line are able to be switched. So we are also on a campaign on acting on unsuppressed viral load results. Importantly as well is the funding commitment. We need to also make sure that we have enough resources available to sustain this viral load testing, not just equipment, but also reagents. Linked to this, we've introduced as a country the National Health Insurance, of which some fund is dedicated to HIV services and largely antiretroviral therapy and also the viral load testing. Thank you so much.